Good morning, everyone. Okay. Started. Okay. Good morning, everyone. I'm Dr. Sanjana Jaswal. I'm a final year resident, and I'll be taking class for you on darkroom procedures. So, darkroom procedures is an essential examination of the eye, which is important for ophthalmic practice. And you, as undergraduates, should be aware of the different darkroom tests that are available and that help us come to a diagnosis. So, the different darkroom tests are: first is oblique illumination, distant direct ophthalmoscopy, retinoscopy, and indirect ophthalmoscopy. Indirect ophthalmoscopy can be done with an indirect ophthalmoscope or with the help of a slit lamp, which is known as slit lamp biomicroscopy. So first, coming to oblique illumination, the objective of oblique illumination is to examine the external and the anterior segment structures of the eye. The instruments that are needed for oblique illumination will be a good illumination beam with the help of the magnification aid like a loupe or even a microscope. The method is we have to illuminate the eye at 45 degrees in order to examine the structures. Slit lamp is an example of oblique illumination where you can see in this image that the ophthalmologist is examining the patient, and the patient is made to rest his chin onto the chin rest, and the ophthalmologist is viewing through the microscope. So this machine is known as slit lamp, and it is a low power microscope which is combined with a high intensity light source that can be focused to shine in a thin beam. So there are various illumination techniques that can be used in slit lamp. The image on this slide you're seeing is the optical section, where you can see that just with a slit beam, the eye has been cut into a section and you can visualize different layers. If you can see my cursor, this white line here is the cut section of the cornea, and this is by this we'll be knowing the thickness of the cornea. After that, we have this dark area, that is the anterior chamber. And then this structure here, biconvex structure, is the human lens. So that also it shows in different layers, the cortex, the nucleus, and then just behind that, if we focus, we'll be seeing the vitreous cavity. So this is how a slit lamp cuts the eye into a section, and this view of illumination is known as optical section. There are various other viewing illuminations which can help us examine the eye, that is a diffuse illumination, direct or indirect illumination. So direct illumination is when we are focusing the illumination beam directly onto the pathology. Like for example, if there is a corneal opacity, the illumination beam is directly thrown onto that. That illumination is called as direct illumination. Indirect is when we want to examine a part of the eye, but we are illuminating another area so that the light rays which are reflected from that area will help us visualize the pathology. Another illumination is the retroillumination. This illumination helps us know how the glow of the eye is, and that depends on the clarity of the media. So examining the lens structure or the glow or the media clarity can be done with the help of retroillumination. Then we have a type of illumination which is known as sclerotic scatter, and then there is fundus observation. And yeah, so along with the examination of the eye as a section, we can use other instruments to the slit lamp, like we can use a gonio lens, and with the help of gonio lens we can examine the angles of the anterior chamber, or with the help of a 90D lens we can even examine the retina of the patient just by making the patient sit onto the slit lamp. And when we examine the fundus of the patient on a slit lamp, it is known as slit lamp biomicroscopy, which I'll be discussing again in my further slides. So, the slit lamp examination uses an instrument that provides a magnified three-dimensional 3D view of different parts of the eye. It starts from the clarity of the media. So media of the eye includes cornea, the lens, the vitreous. Any opacity in the media of the eye can be picked up on slit lamp. And apart from that, from the anterior to the posterior part of the eye, everything can be visualized in slit lamp. So it starts from media, then the cornea, then lens, then the colored part of the iris, front section of the gel-like vitreous can be visualized. And with the help of 90D lens, making the patient sit on the slit lamp, we can even examine the retina of the patient. So this is what this point says here. So the special lenses can be placed between the slit lamp and the cornea or directly onto the cornea to view the deeper structures of the eye, such as the optic nerve, the retina, and the area where the fluid drains out of the eye. That is the draining angle. The draining angle can be visualized with the help of gonio lens, and the retina, the disc, all that can be examined with the help of this lens in this image, which is known as 90D. And this is the ophthalmologist viewing the patient's retina through this lens placed here. And this is the slit lamp. So that was about slit lamp. Now coming to distant direct ophthalmoscopy. So before we go into distant direct ophthalmoscopy, I'll display an image of direct the ophthalmoscopy. This is an ophthalmoscope with its various parts. Here is the switch on, switch off button, and then this. Do you see these dentations here? The disc. So that is known as the tripod, where we can move the different power lenses by just moving this disc. And this small aperture here is the viewing window, and this elevation here is the eyebrow rest. So we hold this little ophthalmoscope very close to the eye, and through the viewing window the patient's retina can be examined. So this is known as ophthalmoscope, but with ophthalmoscope we can also do distant direct ophthalmoscopy. So this is an image where the doctor is doing a distant direct ophthalmoscopy. As the name says, there is a distance between the ophthalmoscope and the patient. And with distant direct ophthalmoscopy, the doctor gets an idea about the media clarity. So objective of distant direct ophthalmoscopy is to examine and classify media opacities against the fundal glow. So when this light is thrown with the help of ophthalmoscope onto the patient's eye, normally we see a red glow, and the red glow looks something like this. But if there is any opacity in the media, like say a corneal opacity or maybe a cataract or a vitreous hemorrhage, this glow will be not seen completely, and in the area of the opacity you will see a dark shadow. So with the help of distant direct ophthalmoscopy, we will know if the media is clear or not. And not just that, we can also know at which plane of the eye there is this opacity. So when we move the ophthalmoscope with our in front of our eye, and if the black opacity seen also moves with the ophthalmoscope, it is known as with movement, and that will be seen in cases where the opacity is anterior to the nodal point, like for example cornea. So if there is corneal opacity, first of all, this full fundal glow will not be seen. A black opacity will be seen in the center, and when you move the distant direct ophthalmoscope, the opacity, that is the dark area in the fundal glow, will also move with the direction of the ophthalmoscope. If you're moving it up, the dark glow will also move up. Similarly, if there is loss of clarity, if there is opacity noted, and if you move the ophthalmoscope but then the opacity is showing no movement, then that is because the opacity is at the level of nodal point, that is the normal lens which is placed at the nodal point of the eye. So if there is no movement of the dark area, then it indicates that the opacity is at the level of the nodal point, very likely lens, that is cataract. So in cataract, when we examine the patient with the distant direct ophthalmoscopy and we try to move the ophthalmoscope, the opacity or the dark area which is seen anywhere in this glowing area will not move. And if the dark glow is moving against, that indicates that the media opacity is behind the lens, that is vitreous hemorrhage or floaters. Anything behind the lens will move against the direction of the movement of the ophthalmoscope. So here in this image you can see that this is how the red glow is seen, and if there is opacity, the red glow is hampered and you'll see a dark area like this. So distant direct ophthalmoscopy helps us view the different medias, as I've already mentioned, that is the cataract, the corneal opacities and the large floaters. Now moving on to, I'm Dr. Sanjana. Yeah. Okay. So now we have the direct ophthalmoscopy. So direct and distant direct are done with the same ophthalmoscope, but the difference is that you see the word distance is not here in direct ophthalmoscopy. That means there is no distance between the patient and the examiner. So the doctor has to go as close as possible to the patient's eye in order to do direct ophthalmoscopy. This is an image here showing an ophthalmoscope, and the objective of doing a direct ophthalmoscopy, unlike the distant direct ophthalmoscopy, is to examine the retina and the fundus, whereas in distant direct we were just examining the media. But then when you want to know even in detail, like what is the cause of the media opacity or what is the pathology in the posterior part of the eye, then we go for a direct ophthalmoscopy. And to do a direct ophthalmoscopy, all we need is a direct ophthalmoscope and a dark room. So, what is the term fundoscopy? Fundoscopy is the assessment of the fundus using an ophthalmoscope. So, fundus of the eye means what we are visualizing is the retina, the optic disc, the macula. So, all that is known as the fundus examination or fundoscopy. So what is the examination technique? How do we do a direct ophthalmoscopy examination to a patient? So in this image, you can see that the room has dim lights. Not really, but yeah. And the examiner is going as close as possible to the patient's eye. And the patient is asked to look at a distant target so that the eyes don't converge. The eyes have to stay aligned. So the patient is asked to look at a distant target, and then we approach the patient from the side. We examine the right eye of the patient with our right eye, and the patient's left eye is examined with the examiner's left eye. And when we start going closer to the eye, we start seeing the optic nerve and the surrounding retina. So this is what this doctor here is visualizing. So he sees the optic disc, he sees the macula, he sees the vessels arising from the optic disc, the arteries, the retinal vein, and not really beyond the equator. So the field of view with the direct ophthalmoscopy is not much, as the magnification is high. So you have to remember this concept that more the magnification, lesser the field. So with the direct ophthalmoscopy, you will have good magnification. That is, it magnifies the retina up to 15 times. And when it's magnifying, the field is going to get compromised. So we will not be seeing anything much beyond the equator here, anything beyond. So in order to visualize this periphery of the retina, we'll have to use another instrument which I'll be telling in my further slides, and that is called as indirect ophthalmoscopy. So till now we have discussed distant direct, direct, and now later I'll be talking about indirect. So in this image, I'll just display the different parts, what you'll be seeing with the direct ophthalmoscope: the optic disc, the vessels, the retinal artery, the retinal vein, the macula, and the center of the macula there is fovea. So we initially start with the distant direct ophthalmoscopy. Then we see if the media is clear or opaque. Then we go closer and examine the optic disc. We see what is the cup disc ratio. We see the vessels, how is the course, the caliber, what is the AV ratio, what is the light reflex, are there any AV crossings, is there any blood banking in the vessels. We examine the macula and the peripheral fundus. So now coming to direct ophthalmoscopy. So that was already done. And one more important point about direct ophthalmoscopy is the field of view increases when you go closer to the patient. So you have to stay as close as possible to the patient in order to visualize maximum field. And also the pupils are supposed to be dilated, because what happens if you don't dilate the pupils is this. So this is an image which shows the part of the retina that you can visualize if the pupils are not dilated. And once you dilate the pupils, this is how the periphery of the retina can also be visualized. Okay, so now coming to indirect ophthalmoscopy. So here again the objective is fundus examination, same as direct ophthalmoscopy. But here, unlike the direct ophthalmoscopy, along with the instrument we'll need another lens which is known as a 20 diopter lens, also known as condensing lens. So with the help of condensing lens and this indirect ophthalmoscope, we can visualize the patient's retina. And one more difference, if you have observed, in direct ophthalmoscopy, the examination is happening only with one eye. The doctor can only use his one eye to examine the retina, whereas in indirect ophthalmoscopy, the doctor is using both his eyes. The view is binocular. Anything binocular comes with its added advantage, that is stereopsis. If you're visualizing anything with both of your eyes which are fusing properly, you will have the property additional advantage of stereopsis. Okay, so what are the different techniques of doing fundoscopy? Till now we have discussed direct, then we have discussed indirect, then another one is the fundus biomicroscopy, that is visualizing the retina with making the patient sit on a slit lamp with another lens, that is 90 diopter lens. And then we can also visualize the retina or do fundoscopy with a contact lens, that is known as a fundus contact lens. So let's see what are the advantages of direct ophthalmoscopy. Direct is the one which I've discussed before, this one here. This is the direct ophthalmoscopy. So what all advantages does it have? First is that it is portable, it's small, so it's easy to use. And it gives an upright image and the magnification is very high. So we can visualize things in detail. The disc appears very large, vessels appear very big. So magnification is high. And we can also use this without dilating the patient's pupil. That's another advantage of direct. But what are the disadvantages? Disadvantages is that because it's magnifying too much, the field is going to get compromised. We get a smaller field of view. Because you're using only one eye to examine, there won't be stereopsis, so lack of stereopsis. And if there is a cataract, if there is corneal opacity or any media opacity, direct ophthalmoscopy cannot be performed because the light that will be thrown into the patient's eye with the direct ophthalmoscope will not be as bright as indirect ophthalmoscopy. So advantages of indirect ophthalmoscopy, here the field of view is larger and it's a binocular instrument, so the doctor has also got stereopsis. And disadvantage is that it requires more skill, and because it's giving us a bigger field of view, the magnification is going to be less here. That is, it only magnifies 3 times, 2.5 to 3 times, whereas direct ophthalmoscopy magnifies up to 15 times. And because one more thing is that the illumination in indirect ophthalmoscopy is very bright. So another advantage of indirect ophthalmoscopy is we can even visualize in media opacities. We can visualize the retina in media opacities. And another disadvantage of indirect ophthalmoscopy is that it requires dilatation of the pupil. So this is an image from UG Khurana, the differences between direct and indirect ophthalmoscopy. I've just captured this from my textbook so that you people can also relate to the same box given in your textbooks. So the different features and how you differentiate direct and indirect, as we've already discussed, condensing lens is used in indirect. Examination distance is as close as possible, indirect, and arm's distance in the indirect. Image is virtual and here it is real. Magnification, direct ophthalmoscopy magnifies 15 times, whereas indirect magnifies only 2.5 times, 2.5 to 3 times. And illumination, you have to remember, it's really bright in indirect ophthalmoscopy, so it can even pass through those media opacities and help us visualize the retina. But in direct ophthalmoscopy, we cannot do so. And the field again is less indirect because it has good magnification, and in indirect the field is good and the magnification is less. Stereopsis, because it's binocular, it's present in indirect, and the accessibility to the fundus view is not more beyond than the equator indirect, but here in indirect we can see up to the ora serrata. And media haze, if the media is hazy, we can examine in indirect, not with direct. Now coming to fundus biomicroscopy. So here you can see that the patient is made to sit on a slit lamp, and with the help of another lens, that is the 90 diopter lens, the retina is being examined. So this way of examining the retina will give us a field of view and magnification which is somewhere between the direct and indirect ophthalmoscopy. That is, the field of view will be less than the indirect ophthalmoscopy, but it will be a little more than that of the direct ophthalmoscopy. And also it depends on the kind of lens we are holding here in using. In 78 diopter, if you are using a 78 diopter lens, the field will be lesser compared to the 90 diopter lens where the field will be more. So it depends on the lens which we are using. And another feature of fundus biomicroscopy is that it gives us an inverted image, and there will be stereopsis present because it's a binocular viewing again. Pupils need to be dilated, and then this requires a lot of skill to see the patient's retina. So this is an image here which shows the normal human retina, and how you describe it is you start with the media. So in this patient, the media is clear. Then we talk about the disc first. First, the disc is a normal sized disc with well-defined margins with a 0.3:1 cup disc ratio with healthy vessels coming out of the optic disc having a AV ratio of 2:3, and the macula is showing normal pigmentation with a central foveal reflex. So this is how you describe a normal retina of the patient, and this is what you'll be seeing in fundus examination. So now that you have visualized what normal optic disc, normal macula and normal vessels look like, we will be seeing now what pathologies look like. So when we are examining the disc, what do we see? We have to first see all these features. We'll talk about the size, shape, color, margins, and the cup disc ratio. Why? Size is important because not everyone has got the same size. Some people have large, medium, and some have small discs. So describing and documenting what is the size of that particular patient's disc is important. So you document the size. Normal size is around 1.5 mm. And then we describe the shape, that is, it's vertically oval or is it tilted. Shape is important because tilted disc is seen in patients with astigmatism. And then we see the color of the disc is very important. Normally it's a pink, but if it gets yellow, as you see in this image and this image down here, the third image, the disc appears very pale. So you see a pale disc in optic atrophy. So describing color is important. Margins, as you can see in the second image, can we delineate the margins? No, we cannot. So that is because the margins are not visualized because this patient has got papilledema. So documenting the margins of the disc and the cup disc ratio. So cup disc ratio is, cup is the central part of the disc, and normally it's 0.3:1. That is, if you're considering the entire disc as 1, then only 0.3 of it should be the cup. Anything more than that can be physiological, but very likely the patient has glaucoma, because in glaucoma the cup size increases as there is continuous loss of nerve fibers. The cup size increases. This image here, you can see the cup is very large here. So nearly about say 0.7:1. In this patient the cup disc is 0.7:1, and here you can see it's 0.3:1. So normally the cup disc ratio is 0.3 and should not be increased. So that's one thing you examine in the disc. And then now coming to vessels. So what all do you see in vessels? First is the vessel diameter, the shape, tortuosity, color of the vessel. Are there any AV crossings? How is the light reflecting from the vessels? And what is the AV ratio? So vessel diameter is important because in hypertensive retinopathy, you can see that there is arteriolar attenuation. So this is the normal fundus that you have seen, and this is the normal, caliber of the retinal arteries. But in this image, if you see, the retinal arteries are very much attenuated. So it's a sign of hypertensive retinopathy. And this image here is actually an image of a central retinal artery occlusion showing a cherry red spot and a very pale retina with attenuated vessels. And then we see the tortuosity. So this image here is showing abnormally tortuous vessels. Normally the vessels are not so tortuous. So tortuosity is seen in central retinal vein occlusion or even in branch retinal vein occlusion. In that area where the branch of the vein has occluded, those vessels will be tortuous. Tortuosity is a very characteristic feature of vein occlusions. Coming to color of the vessel, color is going to go down. The vessel is going to look pale if there is sheathing of the vessel. Sheathing is a sign that there is vasculitis or any kind of inflammation activity going on. And crossings, here in this image you can see that the AV crossing, which is again a feature of hypertensive retinopathy, and different signs can be derived depending on how the AV crossing is happening. That is the Bonnet sign, the Salus sign that you have to read in hypertensive retinopathy. The light reflex and the AV ratio. So normal AV ratio is 2:3. That means the arteries have a caliber slightly less than the veins. A is to B is 2:3. So in case of occlusions, you will see that the vein is becoming more dilated. So it becomes 1:3. And similarly in hypertensive retinopathy, where the arteries are going narrower than the vein. Now coming to the last slides of, this is the last slide, and this examination of macula. Then after you have examined the disc and the vessels, you have to look at the macula. Macula, normally it lies about 2 disc diameter temporal to the optic disc. So this is, if you can see, what does 2 disc diameter means is that normally the optic disc is 1.5 mm. So if you put another disc here and another disc here, so this becomes a 2 disc diameter. So normally the macula is 2 disc diameter temporal to the optic disc. and it's normally pigmented because of its xanthophyll pigments present there. So, and normally macula is avascular. So, in cases of hypertensive diabetic retinopathy where there is neovascularization, the macula starts getting vascularized and that will result in fall of vision. So, examination of macula, normally foveal reflex and a normally dark pigmented macula should be seen. But if that is lost, that means the macula is unhealthy. In this image, this is an image of a patient with age-related macular degeneration where you can see that there are confluent drusens at the macula indicating ARMD. Thank you.